Hello. On behalf of the Roanoke College Alumni Association, I welcome each of you to the series NOKELive. My name is Sally Logan Walker, and I serve the college as the Director of Alumni and Donor Relations, and I have the privilege of hosting today's NOKELive event. Before we get started, please know that each of you viewing on YouTube can use the chat feature to ask questions of our presenters. Once the presentations are completed, we will attempt to answer as many of your questions as possible. Today's event is being recorded and will be available on this YouTube channel for future viewing. A link to all of our past NOKELive events, as well as other online content here at the college, can be found on the Alumni Hub by visiting www.roanoke.edu/alumni. Today's NOKELive event topic is COVID-19 through the lenses of public health and political perspectives. We are joined by two Roanoke College faculty, so let me introduce each of them. Dr. Shannon Anderson joined the faculty at Roanoke College in 2010. She teaches courses in the core of the sociology major. In 2017-18, Roanoke College introduced its new public health studies program with Dr. Anderson as coordinator. She works not only with students and faculty here on campus, but by connecting with local health institutions and organizations in our community. Given her experience working in clinical research at the University of North Carolina Medical School in the early years of her career, this opportunity to introduce the study of population health through a social science lens is one that Dr. Anderson relishes. Before arriving in Salem, Anderson taught at the University of Virginia, Washington and Lee University, and Hollins University. On campus here at Roanoke College, Anderson is actively involved in one-on-one research with students, advising and participating in events focusing on social and health issues, and especially those where inequities exist. Dr. Brian Parsons is an associate professor and chair of the Department of Public Affairs here at Roanoke College, and primarily teaches courses in public policy, research methods, and state and local politics. His research examines the interconnections between actors and institutions and political networks throughout the public policy process. Drawing from theories of social capital and collective action in politics, his current research focuses on how public and private organizations form public policy networks to share information and coordinate policy decisions at state and local levels. He uses social network analysis, SNA, to examine how local governments, state agencies, and nonprofit organizations cooperate in the implementation of public policy. Dr. Parsons earned his doctorate in political science from the University of South Carolina after graduating from Appalachian State University. And now it is my pleasure to turn it over to our presenters, and I believe we will welcome Dr. Anderson first. Dr. Anderson, when you're ready.
Good morning, and thanks so much to everyone for joining us here online for NOKELive. Brian and I will start off with a few comments from our respective fields, and then what we're really excited about is opening things up for conversation and for your questions. I'm going to organize my remarks in two areas. First, I'm going to give us some basic public health descriptive data and concerns as they relate to COVID. And second, I'm going to draw on my own training as a sociologist and offer some sociological framing of why we are where we are now. So I'll start with public health. And it probably makes sense, given that some of you are here in Southwest Virginia, but many of you are not, to offer an update of where things are in this part of the state. So I'm going to share some data from the Virginia Department of Health as of August 25th. That's the most recent data I was able to get my hands on. So the Roanoke City and Allegheny Health Districts, between the two, have about 2,500 current total cases. About 226 of those cases are active. Salem itself has 146 total cases, with 18 new cases in the week ending on August 25th. In our area, 20% of those who have tested positive self-identify as Hispanic. And we actually have a lower positivity rate than most of the state, than the average of the state, I should say, with about 4.8% positivity here in these two health districts. More broadly, you probably have a pretty good picture of where things are. I just want to share a few numbers from Johns Hopkins University as of last night. So globally, there are over 25 million cases total of COVID and 849,303 deaths. In the US, we now have 6,028,617 total cases and 183,579 deaths. What that means is that as of yesterday, the United States accounts for more than 21% of all global deaths. That's a number that we really have to think closely about. So what should we be doing? We all know what we need to do. We need masks, we need social distancing, and we need to avoid being in big crowds. These are things we all really know by this point. We also need to build trust in our community institutions. This is a big problem. It can be very hard to know where we should be getting information, and that's really part of public health work. Another thing that we really need is to develop unified systems of testing and care. And once there are vaccines, systems of manufacturing, distribution, et cetera. But all of those need to be unified systems rather than scattershot, which means that certain populations get missed. The last thing from the public health side, and then I'll shift gears, is the ongoing conversations about concerns about the return to public institutions and the surges that we're seeing in college towns. So many of you have seen, for example, there are now over 1,200 cases at the University of Alabama. I believe this morning I saw that one of the big schools in Ohio, it may have been Ohio State, was over 800 cases. No, that was Iowa State, sorry, over 800 cases. These numbers are alarming to some, but we need to deal with them, not just be alarmed by them. We need to figure out how colleges should handle these situations, how the communities that colleges exist within should handle them, because while there are these clear health concerns, there are also significant economic impacts that affect the lives of everybody in these regions. Last thing then is we're just edging into a conversation about vaccines, and that's something that we're going to have to handle very carefully. And again, the most unified possible approach would be beneficial. So now shifting to the sociological perspective. Why do our numbers look the way they do? Why are we over a fifth of all global deaths in this pandemic? And there are two things I'm going to address. One is our culture, and the other is the politicization of the virus. Of course, I'm going to let Dr. Parsons really handle that latter one. I'll talk about it from a sociological angle. So when I think about our culture, we have a deeply individualistic culture that has done wonderful things for this country in so many ways. Our concerns about freedom, liberty, are part of what have made the United States such a successful place. They've allowed us to feel empowered, to have accountability for our actions, to really create new lives. But right now we're in a moment where we seem to have skidded past a healthy kind of individualism into a kind of hyper individualism that is getting in the way of how we handle this pandemic. So if you think, for example, about our lack of universal health care and about our poorly funded and poorly understood public health infrastructure, it's easy to see how those are related to an individualistic culture that says each man for himself, right? And that can be problematic when we're trying to deal with a communicable disease across the entire society. The other part, and this is the part that has led to a lot of kind of scary public moments, is the lack of adherence to necessary behavioral changes to reduce the spread and contain COVID-19. The most obvious example here being masking. So the second thing I just want to map out a little bit is the politicization of COVID, and especially the role of a bifurcated media. So we live in a media environment where people can live in a media bubble. They only hear things that they agree with, that make sense to them, etc. And what this is creating, rather than health concerned behavior, is partisan behavior. Again, this is part of our problem in terms of spread of disease. There has also been a pitting of concern about the economy against concern about the pandemic. We must think about these two things together. There are some great minds doing just that. The best example that comes to mind for me is an op-ed written by Neil Kashkari, who is the president of the Minneapolis Reserve Bank, and Michael Osterholm, who is a leading figure in public health at the University of Minneapolis, who together wrote an op-ed about how in order to save our economy, we must contain COVID. And yet our media, again, tends to pit these things against each other. Another thing that I know is harder to deal with because it's a little bit less tangible is distrust in information. So what we see over the past 4 years is this ongoing narrative that says, this is fake. You don't have to trust it. And that has made it really hard for just average people sitting and watching the news to know what's real, to know what to believe, who to believe, what institutions they should trust. And the way we respond to that has been largely predictable in a lot of ways, but there are some groups that are reacting in ways that aren't as politically predictable. So for example, if you know anything about medical history and African Americans' distrust in institutions, this goes way back. And as I mentioned earlier, we need to really think carefully about rolling out a vaccine, in part because of the partisan issues I was just talking about, but also because among certain populations like African Americans, there is this really significant historically held distrust of our medical institutions. And therefore that population is also saying, we don't want to be first in line for that vaccine. So there are many layers to this. Some are more obvious and more politically clear, some less so, and we also need to address those. There's also been this kind of hardening of divisions locally, nationally, et cetera, about reopening that also seems to be linked to this politicization. So I'm going to stop now. I just want to say a couple last things before I throw it over to Brian. We're in a moment where there is no 100% risk management. We can only mitigate risk. We can't control it all. And so what we need to be thinking about as a society is how can we work together to create as much safety and normalcy as possible. We can't do all one or all the other. We really need to figure out how to maximize both. And it's hard. And we're not in a moment where we're talking to each other very well. And so I think I will end there, and I look forward to questions, but now I'm going to throw it over to my colleague, Dr. Brian Parsons.
All right, thank you. Thanks again for everyone tuning in to this NOKELive event. Let me first say that I am not an epidemiologist, nor am I an infectious disease expert, so I cannot comment on specific public health steps the U.S. Should have taken or should take going forward to combat COVID-19. I'll leave that to other experts. I'm just a political scientist, so So my remarks will focus on how COVID-19 intersects with important features and trends in American politics and public policy. The first point I want to make this morning is that it is impossible to understand the US policy response to COVID-19 without an awareness of one of the defining institutional features of the American political system, federalism. Anyone who remembers taking Introduction to US Government in high school, or even our Introduction to American Politics course here at Roanoke, may immediately think of cake when I use the term federalism. That is perfectly normal, and who doesn't like cake anyway? So let me explain. Our federal system in the United States was designed with two levels of government, the national and government in the states, to share responsibility for governing the nation. And for nearly 150 years after the ratification of the Constitution, these two levels of government carried out distinct responsibilities, kind of like a layer cake, with the national government mostly coordinating issues of things like, say, defense, commerce, foreign affairs, and state governments mostly coordinating everything else. In fact, this is the spirit of the 10th Amendment to the Constitution. For many reasons I don't have time to go into here, the 20th century saw the relationship between the national and state governments evolve into one of interdependence, kind of like a marble cake, meaning that the national government relied on states to carry out, national policy objectives, and states relied on the national government for resources to do so. This, of course, brushes over many nuances and conflicts involved in what political scientists call intergovernmental relations, but you get the basic idea. And some constitutional scholars have very strong opinions about which type of federalism is better. For me, I just like talking about cake. So how is any of this related to the US response to COVID-19? Well, one can imagine how our federal system could work to our advantage in fighting a global pandemic. After all, state and local governments are closest to the people and may be able to, tailor public health policies and guidelines to specific needs of their communities. And in fact, we saw some evidence of this early in the pandemic, with states adopting different public health precautions in response to outbreaks they were or were not having. For example, a little over half of states had enacted stay-at-home orders by the end of March, and many of these states were either experiencing outbreaks of cases or were neighbors of states that were. What followed over the next several months and continues today is variation in policy responses that are specific to each state's experience with the pandemic, from face covering requirements to bar closures to bans on large gatherings and so on. And in many ways, this is American federalism operating exactly as designed. Another reason that American federalism could work to our advantage in fighting a pandemic is that historically public trust in state and local governments has been higher than trust in the national government. In fact, local governments are rated the most favorable of all levels of government, and that's true today as well. A YouGov poll from late April found that 38% of respondents rated the federal government's COVID response favorably, compared to, and get this, 55% of respondents who rated state and local governments' COVID responses favorably. A Pew Research Center poll in early August found basically the same thing. As my colleague can probably confirm, fighting a pandemic with sound public health policy is easier when the public trusts the institutions that are responsible for it. So a federal system that combats COVID-19 via state and local governments may be better situated, at least in terms of public trust, to obtain compliance with health and safety precautions. So what's the bad news? Okay, well, the bad news is that the US response to COVID hasn't exactly played out this way, at least not in all areas. While there have certainly been successful state and local responses, and here I'm thinking of New York or New Jersey, for instance, one of the downsides to American federalism is the patchwork of policies that create an uneven experience for many citizens. For example, according to the Kaiser Family Foundation's database on state health policies, some states have expanded access to things like telehealth services and paid sick leave, as well as using the Medicaid program to cover, COVID-19 testing for people without health insurance. But many have not enacted these kinds of policies. Even today, 6 months into the pandemic, data from Johns Hopkins Coronavirus Resource Center indicates that the capacity to test and contact trace for COVID-19 varies tremendously by state. And while American federalism has its advantages, A glaring disadvantage is the problem of coordination, especially when a national problem requires it. A national crisis that affects all states and in many cases outstrips state and local capacity requires some kind of coordination from the national government. And a strange coincidence, there is a story on the front page of the Wall Street Journal today, I'm not kidding, that outlines in great detail the policy decisions made early in the pandemic by leaders in the executive branch that sent our federal system's ability to basically create and maintain a supply chain for COVID-19 resources into a complete tailspin. In fact, the story begins with a report from hospital administrators and state officials that describe, the early response as a nationwide free-for-all. In addition to the problem of coordinating policy across the states, one of the challenges in a federal system of government is political accountability. With many states still classified as hotspots, to whom or what will the public attribute responsibility for our response? In a federal system of government with overlapping responsibilities in the national, state, and local governments, how can the public hold leaders accountable for policy decisions, both the successful and unsuccessful ones? And in our federal system that's stumbling its way through a fragmented policy response to COVID-19, it seems tailor-made for leaders to take responsibility for things that go well and shift blame for those that don't. So in American federalism, everyone is responsible and no one is responsible at the same time. And so before I finish, I want to return to a point I made a few minutes ago regarding public trust in institutions. In my corner of the academic universe where we study politics and public policy, one of the most consistent research findings in my field is that public policy can actually shape politics going forward. Successful policies alter our politics in important and interesting ways, and so do unsuccessful policies. And so in addition to the coordination problems I've just described, another lingering concern of mine as a political scientist is the extent to which public institutions that we will need to rely on to effectively fight this virus, have been politicized, often along partisan lines. And here I'm thinking of public trust in institutions like the CDC or the FDA. Both have been the target of political rhetoric and pressure, some of which by the president, yes, for which the consequence is a growing partisan gap in institutional trust. A recent Pew Research Center poll finds a 20-point gap between Democrats and Republicans in their trust in public health officials such as those at the CDC. And this may seem like typical partisan politics for those who are watching this webinar, but it matters moving forward if partisanship affects not only trust in public health institutions, but even compliance with public health guidelines, such as face coverings, distancing, and an eventual vaccine. In fact, a recent study published in Political Behavior, which is a leading journal in political science, presents evidence for this very thing. So that concludes my brief remarks. And again, thanks to everyone for tuning in. And Dr. Anderson and I are happy to answer your questions.
Wonderful. Doctors Anderson and Parsons, thank you so much for giving us some new insight into this pandemic. I am ready to facilitate comments and questions that we're receiving from the viewers. So I'd like to begin. I believe we had a comment first from Labada Guthrie. Labada says, we didn't have, sorry, my screen is moving as I'm trying to read. Sorry, we didn't have a viable federal response, exclamation point. Our state has done a much better job of laying out guidelines. That was her comment. I don't know if either of you would like
to. I know her.
Do either of you want to respond to that?
Yeah, I mean, I think that more or less captures the point I was trying to make in my remarks. That our federal system is positioned in a way that you could theoretically imagine it being really useful respond to state and local needs in the midst of a pandemic. But the flip side of that is what it does require is some kind of coordination on the national end, which I think is fair to say has been lacking over the last half year or so.
And I would just add less from the policy specific side. Virginia is a tricky state because the constituencies of different parts of the state respond really differently to the kinds of policies the governor has enacted. So early in the pandemic, my 13-year-old daughter and I actually watched Governor Northam's addresses each week. We found it sort of interesting to watch. We usually were watching online, and the comments that came from our part of the state, and I only know that because we were watching on local television, did not think that the responses were so great. And so again, to go back to this problem of even partisan viewing of what we see on television, is that the responses are so very different.
Yeah.
Okay, so we had 2 questions that came in about the CDC. So I'm going to read both of them. So the first says, is there any valid reason not to trust organizations like the CDC? Mm-hmm. The second question is specifically from alumnus Bob Spillane. And he said, last week, CDC changed testing guidelines. In quotes, you do not necessarily need a test unless you are a vulnerable individual or your healthcare provider or state or local public health officials recommend. So that may be 2 really separate questions, but they both relate to the CDC. So I thought I would just put them out there.
So I'm happy to jump in first, and then I'm sure that Dr. Parsons can answer again from that more governmental side. The CDC has now been put in an incredibly difficult position. CDC used to receive all of the data from hospitals across the country about COVID until a few weeks ago now, I guess, this administration prevented that data from being sent to CDC. And while I trust the people who work there and who are doing their damnedest to do their jobs, I'm really concerned about their lack of access to data, because they're not getting that day-to-day kind of data from hospitals across the country. I also think that the kind of political pressure being placed on CDC is making their job much, much harder to do. So then the second thing about them changing their policy, I really view that as a response to the kind of pressure they're getting. But what's interesting is that the reaction was so negative and so fast to that order that they've actually walked it back a little bit, not completely, but a little bit. And so it's interesting to watch how these institutions that we tend to think of as stalwart and making these decisions that stand are having to be so responsive in a way that's really atypical, I think, in their existence.
Yeah, and I agree with all that. I mean, I'd also say that, the CDC's in a tough spot. This isn't the first time the CDC's changed its guidelines. And unfortunately, instead of, the reaction being one of, okay, well, this is an evolving kind of problem, for which experts are going to learn new things and then have to change, policy recommendations. Those changes have been used as essentially fuel to the fire to further, I think, question the institution's legitimacy or whatever. And another way to read the CDC's recent change is that this may in fact be the CDC's recommendation in the context of limited testing supplies, right? So if we actually had testing capacity in all the states, which doesn't exist, it's not unreasonable to think that those guidelines would look different. But we're kind of well behind the curve in terms of testing capacity. So.
And I must apologize. Bob had more to his question, but I believe we addressed it. So Bob, if we did not address all of your questions, just let us know. So we had another question from Lavada. Dr. Parsons, how do we ensure that our most vulnerable populations are protected from the next pandemic if there is another lack of urgency in our population?
Well, I think it's a good question. What I hope is that this crisis is enough to convince policymakers that investing in public health is pays dividends, right? It's difficult sometimes in our politics to kind of get our minds out of short-term political gain, but there are many problems like this pandemic that do require long-term investments. And so, once we get through this storm, again, my hope is that policymakers at all levels of government, but certainly at the national level, will start investing in public health security in a way that maybe we certainly we haven't recently. And this is pretty consistent with how political scientists understand the policy process. I mean, sometimes external shocks to the system are enough to, get the attention of policymakers, focused on new problems. Not unlike, say, the 9/11 attacks refocus policymakers' attention on new problems. Now, that isn't to say that every policy that came from that period is a good one or an effective one, but at the very least, in terms of protecting our most vulnerable populations, I think investment in public health has to be priority number one.
Okay, we have lots more questions coming in. So I'm gonna ask our next one, which is from Pam Sabaka. We understand the issues and the problems of coordination between federal and state governments to the point of everyone is responsible and no one is responsible. How can that be changed?
Good question. This is an enduring kind of problem in a decentralized kind of political system. And I don't want to, for folks watching, even if there are some alums and students I've had in class, know that, I take great joy in teaching about federalism and the values of the advantages of federalism. But yeah, it's a real problem because so many of our public policies, I mean, I know this is a COVID-19 kind of talk, but put that to the side for a second. I mean, you can think about, issues in healthcare and education and homeland security and immigration. And I mean, nearly every, in the environmental policy, nearly every single policy area in the United States government is touched by this shared governance. And so it does become very difficult to disentangle. Some might argue that, well, the way to address this question is to go back to the way federalism worked 150 years ago with very distinct responsibilities in the national government and state government. Then who's responsible for what. I don't know that I fully buy that, buy that argument. But some simplification of how our policies are designed, how they're implemented might help. But certainly the fragmented media environment that Dr. Anderson mentioned, just compounds the problem there. So I'm sorry, I don't have an easy go-to solution for that.
Dr. Anderson, any response, or do you want me to move to the next
You
question?
can go ahead and move on. I would say many of the same things Dr. Parsons said.
Okay. So we have our next question from Karen Nutzi. Karen, I hope I said your last name correctly. When so many cases are asymptomatic, how does this align with the change in the CDC guidelines on testing being unnecessary unless symptoms appear?
So this is why the reaction to that change in policy was as intense as it was, is that people were asking exactly this question. We know that at least 40% of the cases are probably asymptomatic, which means if those folks are not being tested, they're walking around and potentially spreading COVID. Having said that, there are other approaches. I want to be clear, I'm not advocating them. I just, it's worth saying, if somebody is asymptomatic but knows they've been exposed, they can quarantine. They can self-quarantine for 2 weeks, and that then makes them fairly safe. The other thing is that if we all were wearing our masks and keeping the appropriate amount of physical distance between us, we would also probably be okay. The problem is, as I'm sure you're intuiting, we're not all doing those things. We go out in public and there are people that clearly are not participating in those community saving behaviors. And I think that's why the concern about CDC's response is so great. We also know that our executive branch doesn't want testing because they think that's what leads to cases. And so there's also this sense that there's a political motive. And I think that concerns a lot of people too. In terms of safety, I think that really the best advice is still to avoid gatherings with lots of people, to try to keep distance and wear those masks, because there also simply isn't a clear enough system of testing for everyone to have access. So for example, I have not seen my parents in many months. I would love to, but it's not going to be easy for me as an asymptomatic, healthy seeming person to walk into a doctor's office and say, hey, I really want to test so I can go see my parents. And all of this complicates the matter.
Dr. Parsons, did you want to comment or for me to move on?
No, that's it. Yeah, that all sounded
So
good.
we have a question from a very recent graduate, Gaston Ocampo. Hi, Gaston.
Gaston.
Hi, Gaston.
We're so glad you're here. He asked, what are the implications for U.S. health projects abroad, like USAID, when the world is realizing that the country lacks a coordinated response to the virus at a domestic level?
They're big.
Yeah.
There's a lot of distrust of the country right now in general, but particularly in terms of health. And we've even withdrawn, as you all know, from the World Health Organization. This is going to make it harder for us to do the really good, important work that we've been doing around the world for decades, for a very long time, and usually in coordination with other countries around the world. So I'm sure that there's a more policy related kind of response to this, but I worry a lot because US dollars, so for example, I've done a lot of work in the HIV world, have been hugely important, the PEPFAR dollars, in improving health and lives around the world. But I worry that that money may be less welcomed as a result of decisions we're making domestically.
Okay.
Yeah, I agreed. All I'll add would be that, a domestic policy response that, and again, not to be unfair, but a domestic policy response that sends the signal that all the states are kind of on their own, right? It does not speak well to what the U.S. involvement in global projects might look like either.
So we have about 5 more minutes, and I'm going to take these last 2 questions that I've seen pop up on the screen. So the first is from alumnus Rodney Whitlock. Hi, Rodney.
Hi, Rodney.
And he asks, are we de facto seeking herd immunity while awaiting a vaccine?
Well, there was Rodney knows this. We're not going to say anything that Rodney doesn't already know, let's be honest. But
He's
there's
asking for everyone, I bet.
There's a report in the Washington Post yesterday, I think, maybe yesterday evening. So it might be in the actual print edition today, about some rumblings within the administration considering maybe not just a de facto, but a very explicit herd immunity policy, which is, so to Rodney's question, it seems that way. I mean, that's the short way to answer it.
Yes, the newest physician who has been added to the COVID response team that reports to the executive branch is a doctor who I understand is a very well-respected radiologist, but not an infectious diseases physician. And he appears to be aligned with the executive branch's desire to reopen and believes that this herd immunity strategy is the way to go. And in fact, is talking explicitly about following Sweden's model.
Yeah. Right.
Okay, our final question is from Alexis Barton. Recently, Maryland joined a coalition with 6 states to include Louisiana, Maine, Michigan, Ohio, Virginia, and North Carolina to create a cooperative testing program. Is this the future of public health? Does this further the politicization, I cannot say that word, sorry, of COVID?
Well, I'll let Dr. Anderson weigh on the public health part of that question, but what I'll say is this is, in the many advantages of federalism, these kind of interstate compacts and efforts at coordination isn't new. It's not a new phenomenon. States have been doing this for a long time, actually, across a range of different policy issues. Thinking of interstate compacts to manage shared, bodies of water, or something like that nature. So this may be the way, at least from my perspective, from policy standpoint, in the absence of national coordination, national leadership, this may be the best option that state governments have, in trying to create some uniform response going forward.
Right, I completely agree. And in terms of the question of, is this the future of public health? Gosh, I hope not. Because while it's really important in the absence of more national leadership, it remains limited. We move around in this country at the level of mobility in our lives is such that just having 7 states work together, unfortunately, isn't enough to protect populations. It helps for sure. Don't get me wrong. I'm glad they're doing this. I'm glad that some leaders are making this kind of effort. But without question, public health has to happen at a broader level, particularly when we're talking about communicable diseases, right? Or we're not able to bring down numbers and then contain those low numbers, right? So I think about Roanoke in June. Roanoke in June had very low numbers. Things looked good until things opened back up, because we had essentially managed to contain the disease here. We didn't have very many cases. We were able to get them into the hospital, be really careful, et cetera. Once things opened back up and traveling began again, we all know what happened. And so while I applaud these leaders for making the effort, I really hope this is not the future of American public health.
Well, that wraps up today's session. I want to personally thank Dr. Anderson and Dr. Parsons for providing us with your expertise and insight into this topic from such a unique perspective. I want to thank all of you who have joined us today for our NOKELive event via YouTube. I hope that you will continue to all join us for future NOKELive events. Our next one that we have scheduled is Thursday, October 1st at noon, where we will take a look at art beyond the walls. So we'll take a look at 3 unique approaches to art at the college. So I hope you will join us for that. For more information, again, visit roanoke.edu/alumni and visit our alumni hub, where you'll find information on all of our NOKELive events. Thank you all. Take care, everyone, and stay well.
Thank you. Thanks
Hey.
for having us.